Welcome everyone to the supportive housing webinar series. We've kicked this off with several topics that we wanted to cover in response to some of the training needs and kind of informational needs that we were hearing from some of our supportive housing providers. We also have shelters that may be joining us as well that are interested in learning about these topics. Today's webinar topic is about our assisted outpatient treatment program. Many of you have heard of them, but there's a lot of intricacies and details that go into bringing this program to life and a lot of folks involved. And so we thought it would be great to share kind of the basics, the ins and outs, an AOT 101 on how to make a referral, who's eligible, who's best suited for this kind of service. Some of you may already have some communication with AOT and or a care coordinator who works with some of your residents and tenants. And so we thought this would be a really great opportunity to share this information with you all. I'll kick it off with brief introductions of the folks on our panel today. I'm Kathy O'Sullivan. I'm the Executive Director for Mental Health Programs here at the Bureau of Mental Health at DOHMH. I'll turn it over to our partners at OMH.
Good afternoon. I'm Karen Abbott. I'm the Director of Housing.
Gail, I see you're there. I'll turn it over to our colleagues here.
Hi, good afternoon. Gail Walsh, the Office of Housing Services, DOHMH. More H's.
More H's. It feels like it these days. And our colleagues at AOT. Angelina.
Hi, good afternoon, everyone. I'm Angelina Olivares. I am the Deputy Director for our Quality Improvement Team with Assisted Outpatient Treatment. And I'll turn it over to Melissa.
Thank you. Good afternoon, everyone. Thank you for joining us. My name is Melissa Siegerman. I'm the Quality Improvement Specialist for the AOT program within the 5 boroughs of New York City. Thank you.
Excellent. Thank you for joining us. And Cynthia, you want to do a quick shout out? We can't live without our admin help. Okay. Maybe Cynthia's not able to hear us at this moment, so we'll get started. I think we'll jump right in. Just one thing that I kind of want to reference as we get started. The way we've been doing the webinars, because it's a lot of information, is that we're ensuring to save enough time at the end for Q&A. So because this is a large webinar and folks don't necessarily have the ability to unmute themselves, we're asking folks to please plug in your questions in the chat or in the Q&A section, whichever is most comfortable, and we'll kind of lump them up, categorize them, and get to it at the Q&A part, just so that you can kind of get the full presentation without interruption. We might answer some of your questions throughout the presentation. So without further ado, I'll turn it over to our partners at AOT to get started. Thank you.
Thank you, Kathy. And again, welcome everyone. Thank you for inviting us to be part of this presentation. And happy Friday, everyone. And I hope everyone's staying cool right now because it is very warm out there. But let's get started. So we are here to do a presentation on assisted outpatient treatment program. So what is assisted outpatient treatment? And it's also known as Kendra's Law. It supports our engagement in mental health services for our adults living with a history of multiple hospitalizations or harm to self or others due to noncompliance to treatment. AOT reinforces treatment, mental health services, and recovery through monitoring the compliance of both our individuals, our patient, our clients, our consumers, what we call them in AOT, and their providers to a Silver Court Order Care Coordination Treatment Plan. AOT is implemented by Department of Health and Mental Hygiene staff, also known as DOHMH, working with community-based case managers, including clinicians, within ACT teams, IMTs, and clinics. And we're going to talk a little bit more in detail about that and how that works. And just to briefly kind of mention Kendra's law is the attempt to make something positive out of a negative event. It mandates a government to provide services for those who most need them in the community. It, as I mentioned before, it requires individuals who meet the certain criteria, which we're going to talk a little bit more about criteria to comply with mental health services mandated through civil courts. It is the least restrictive form of treatment than inpatient facilities. It ensures that services needed for individuals are accessible. And who do we serve? We serve individuals who have a documented mental illness, those who would not seek treatment easily in the community, and those who are unlikely to live safely in the community without mental health treatment. And this is just some data in terms of the level of care mandated for our individuals with AOT court orders based on our fiscal year for 2023. And absolutely, we'll be sending a copy of this presentation. Thank you so much, Kathy. And as you notice here, the majority of our consumers have providers such as an ACT team, assertive community treatment program, and care coordination with a clinic provider. So it's 45% with an ACT team. For care coordination with is 38%. We also have individuals, which we call them consumers on our AOT roster, who are receiving services through a shelter ACT team. And these are specifically ACT teams who work with our shelter, who are consumers have been in shelters, and kind of bridging that gap to ensure that our consumers end up in supportive housing. And 5% of our individuals have a shelter ACT team. We also have FACT teams, which is a forensic part of an ACT team. These are individuals who have history with criminal justice. And we also now have IMT, in terms of mobile treatment programs, and that is 7% of our consumers who have that care. And this is our AOT teams that consist of 4 teams. We're all located in Long Island City office. And we have the Manhattan team that includes correctional, such as Rikers, state, prisons. Then we have our Brooklyn and Staten Island. We have our Queens and our Bronx team. And as you can see here, there are numbers here that you can also utilize for when you want to make a referral, or for instance, if you're trying to reach out to somebody in that specific borough and team, then this is the number you can also reach for your information. Now, what is our AOT team? What do we do exactly? And I just want to kind of briefly mention what we do and our responsibility. So we determine eligibility. We're going to go into more details about what that looks like as well. We help in developing and approving treatment plans. We file petitions when appropriate. If a consumer is determined to be eligible for AOT. We monitor and ensure compliance with court orders and voluntary agreements. We provide the support to our providers in their efforts to engage our consumers in the community, because we know that it can be very difficult for our providers in the community engaging our consumer on a weekly basis, because many things do occur, and we're going to talk about what that looks like. But we're here to support our providers in the field. We file for renewals And I just want to mention and clarify with folks here that we don't directly treat our consumers on AOT. The providers, such as the ACT teams or IMTs or care coordination in clinics, they're the ones who are providing the mental health services to our consumer. We're just really there to kind of monitor and receive the reporting as to how things are going with the compliance with our consumer. And how does AOT work? So as I mentioned before, each consumer will receive direct services from an ACT team or an IMT or care coordinator plus an outpatient clinic. These services are added to the treatment plan, including others. And other services can be housing, you all can be in this treatment plan. And it's really great because then we kind of bridge that gap in terms of communication, in terms of like being able to discuss how our consumers doing. So the ACT team or IMT or care coordinator can definitely reach out to housing providers to see how things are working, how things are, how is the consumer presenting at the residence, things of that nature. The providers then they submit weekly reporting via our portal. And this is where our case monitor reviews the weekly reporting. If something alerting does come up, is a conversation that our case monitor on AOT will follow up with our providers, including they are required to have a monthly service verification. This is a clinical discussion that happens between our providers and our AOT case monitor in terms of how our consumer has been doing for the month. There's a discussion about significant events, incidents that have occur, whether it be at the residence, whether it be at the private home, whether it be situations that led to hospitalizations or situations that led to criminal justice involvement. So all that goes into those service verifications on a monthly basis. And the responsibility of our AOT case monitors, our AOT program, they're there to review the weekly reports submitted by the providers, that the reports the progress that the consumer is making towards recovery and indicating, as I mentioned before, any issues that need to be addressed. They also participate in case conferences as needed. Perhaps there's been a pattern of hospitalization, or there is a pattern of consumer non-compliance or partially compliance. There's some major risk concerns that may benefit from conferencing and meeting with all parties involved, including the provider in the community, including AOT, including sometimes our partners at OMH. So this is definitely something that we work towards being involved in. We discuss and follow up on issues that can arise, providing, technical assistance when needed, reviewing treatment plans, participating in decisions to renew a petition. And we definitely will discuss more as to what goes into that. We work with our consumer psychiatrists, AOT psychiatrist, and treatment provider whenever a consumer is not engaging in treatment. These are some of the benefits of AOT. So when a consumer is on AOT, there is a priority for services. There is a priority for them to receive an ACT, slot, because we know that ACT slots, there is a major wait list. But when someone's on AOT, they have priority for that. They have priority for IMT services as well. and care coordination with clinic. There's a benefit where there's assistance from Department of Health and OMH resolving any service access concerns. So let's say there is concerns regarding housing. This is where, DOHMH, the case monitor, the supervisor at AOT, the assistant director at AOT can definitely be included in these case conferences with OMH's assistance to kind of address the concerns that our consumer may be having at the residence, or maybe having, with another individual or roommate, things of that nature. There is definitely assurance that our consumer will be followed by a care coordinator. And that's a mandate that someone will be providing that treatment for our consumer while they're on AOT order. And an evaluation for hospital admission before crisis. And these are some of the expectations for our providers. There's definitely collaboration with hospitals and other providers and consumers treatment plan. Examples of other providers can be the clinic, our housing providers, hospital and parole. There is weekly electronic report of service. As I mentioned earlier, those are the weekly notes that the providers enters. There is those monthly service verification. As I mentioned before, those are the clinical discussions happening every month. Providers are meeting with their consumers as mandated frequency on the AOT order. And just to kind of break it down for ACT team, the expectation is that they're meeting at least 6 times per month with our consumers. For care coordination and for IMT is 4 times per month. There's also submission of significant events within 24 hours whenever an untold event occurs. And we'll kind of like go over what are some examples of significant events and what does that look like. And these are the reports that are sent by the provider into our portal. Notification where providers are having difficulty accessing services for the individuals that they serve. Okay, now I'm going to hand this over to Melissa. Thank you so much.
Thanks, Angelina. So we're going through a little bit of the referral process for AOT right now. So ask before you refer. If you are a housing provider or a DHS or really any resource in the community, these are sort of the questions to ask yourself before you refer the client to AOT. So can the services that the client needs, can it be mandated by an AOT court order? The second one is, does the individual really need the AOT court order as a safety net? Do they sometimes need to be taken to the hospital unwillingly? The third question, has the individual had any forms of service before? So have they had care coordination before? Have they complied with care coordination? If not, have they been bumped up to an ACT team or an IMT team in the past? And how has that service worked for them? Were they engaged when they had that service provider? Another question to ask is there any form of mandated treatment that makes AOT irrelevant? So sometimes if you have a client that might be mandated by, let's say, criminal court to engage in mental health services as part of their parole or their probation, right? That might be counterproductive with the AOT court order, even though we do have clients that are on probation or parole and have mandates for mental health treatment under those conditions. Go to the next slide, Angelina. Thank you. So how do consumers get referred to AOT? So this is sort of the breakdown of how clients get referred to AOT. And we'll speak about what an authorized petitioner is on the next slide. But an authorized petitioner is somebody in the community or somebody in a psychiatric inpatient hospital setting that makes the referral to AOT. So, you could have community cases that may be referred from mom, dad, significant other, housing case manager, a therapist at a clinic, or you can have a client referred to AOT through an inpatient hospital setting, whether they're at state hospital or whether they're on an acute unit, such as like Elmhurst Hospital inpatient psychiatric unit, right? So those are just some ideas of really who can make the AOT referral. Once the client is referred to AOT, then we open up what's called an investigation to determine if they meet AOT criteria. Now that investigation timeframe looks different for every person that's being referred to AOT. So I want you guys to just keep that in mind. Once we open the investigation, we determine that they meet criteria, we review the referral, and we've put together a treatment plan. And with the treatment plan, like Angelina was saying before, all AOT clients have either an ACT team, an IMT team, or care coordination with a clinic. There has to be some of those services in place. Now that they meet AOT criteria, it's been determined that they do, and we'll talk about what is the AOT criteria in a little bit, but then we would set them up with an exam with MHLS and a representative. If the client's in the community, this exam would happen with one of our AOT psychiatrists in our office. If the client's on an inpatient basis on an acute psych unit or state hospital, it would happen with the psychiatrist that's treating the client on the unit. And again, like I was saying, the treatment plan would be developed, and we would decide that we're going to move forward with a petition for the AOT court order, and then the case would go to court, to civil court, for a hearing, so that the client can hopefully be placed on an AOT court order if they meet criteria. Next slide. Thank you. So again, authorized petitioners. So this can be somebody in the community. Like I said before, it could be a family member, it could be a roommate, or a significant other. It could really be anybody. It could be HRA, or it could be, again, a director at a hospital, an inpatient team, maybe the inpatient psychiatrist or the inpatient social worker thought that this client, for example, if you have a client, I'm just using Elmhurst Hospital as an example. If you have a client that's had 3 admissions back to back in the past 6 months for noncompliance with, some form of their psychiatric treatment, Elmhurst Hospital might decide at that point that, okay, the client's been here 3 months, they're non-compliant with medication, or they've been here 3 times in the past 6 months, let's petition for an AOT court order, right? So those are just some examples. The Director of Community Services, parole, probation. So really that AOT referral can come from a variety of sources. Next slide. Thank you. Now, this is the criteria to make an AOT referral. Now, the difference to make a referral to AOT and the difference to actually be placed on an AOT court order are 2 different criterias. So the eligibility to make a referral to the AOT program is that the client has to be 18 years or older. They have to be diagnosed with a mental illness. They have to be unlikely to survive safely in the community without supervision. And there has to be a lack of engagement in treatment. Really, that's really what the AOT program is about, is that the client has a history of some form of noncompliance with their psychiatric treatment. Again, they have to be unlikely to voluntarily participate in treatment on their own and independently. The court order treatment is necessary to prevent their relapse or decompensation. So they really have to be able to benefit from the AOT court order as well, is very important. And to some extent, they have to have the capacity to understand what the court order is. Oh, you could go back 1 slide. Thank you. Now, like I was saying before, when a referral is being made to AOT, we get a referral from whoever referred the client. And then we open up what's called an investigation. We have community referral investigations, and we have inpatient hospital referral investigations. So the difference is, we're going to go through it a bit. So when a referral comes from the community, like I said, from family member, parole, a residential staff at housing facility, DHS, that is what we consider a community referral. We call it a community referral is because somebody from the community and our AOT office is petitioning for the AOT court order. So when a client's under community investigation, the exam happens with our AOT office. And keep in mind, when a client is referred through the community, this investigation can take a lot longer to get somebody on an AOT court order. And the reason for that is AOT, in order to determine AOT criteria, we use medical records within the past 3 to 4 years, hospitalizations and arrests that have happened within the past 3 to 4 years. If we have a client that declines to sign a HIPAA form for us to request hospital records, AOT would have to get a subpoena. That could be a lengthy process. So it is most beneficial that referrals come through inpatient, because that referral process can be a lot faster, even though, if you're having somebody that you're thinking about referring to AOT, please do so. But if they are in an inpatient hospital setting, it is really helpful if the inpatient unit decides to petition for the AOT because they have all the medical records already. Usually our clients, sometimes, even though they do go from different hospitals, sometimes our clients go to the same hospital over and over again. So if you have a client that goes to Metropolitan Hospital over and over again, they might decide to petition AOT. If you ask them, they may think it's a good idea. And that exam will happen on the inpatient unit. Even though the hospital's petitioning for the AOT, for the court order, our AOT office still has to approve the treatment plan and what services the client's going to be getting once they're discharged and once they're outpatient. So that's a little bit about the difference between community and inpatient referral. Now, one thing I want to just say is, if you do refer somebody on a community level, like say you are, for example, say you're a director at a housing agency and you refer one of the residences to AOT, and they have an open AOT community investigation, but then the residents, maybe 2 weeks after making that AOT referral, has to call 911 because something had occurred and the client's now on an inpatient psych unit. Make sure you call AOT. There will be an AOT investigator assigned to the case. Make sure you do call AOT and notify them that, hey, the client's on an inpatient unit. Maybe we can ask the inpatient unit if they're willing to do AOT. Sometimes the inpatient doctor might say yes, and sometimes it might be a no, but there's no harm in trying. So again, you can, if a client was referred on a community level and then ends up inpatient, we can ask the inpatient unit to do it, to do the court order, and it'll be up to the inpatient unit's discretion if they do or not. Next slide. Thank you. So this is the criteria for a client to actually get on an AOT court order. Before, a few slides back, we spoke about the criteria to make a referral. This is the actual AOT court order criteria. So again, the AOT program is really for clients that have a history of noncompliance. Now, the first criteria is that the client has had to have 2 or more hospitalizations or periods of being incarcerated due to noncompliance within the last 3 years, or they have to have committed one very serious act of violence toward themselves or another person within the past 4 years. And recently we've had another criteria added to the addendum, where if you have a client that was on AOT and AOT closed their case within the past 6 months, and it's within that 6-month time frame of their AOT case being closed, they can now be referred back to AOT without having to meet these top 2 criteria all over again. So if you have an AOT client and we've closed their case within the past 6 months and you're noticing that they're starting to disengage and not do well, they can be referred back to the AOT program without needing to meet these top 2 criteria points all over again. And again, when you're making an AOT referral, keep in mind that AOT can only use events that have happened within the past 3 to 4 years in court to prove that the client, as evidence that a court order is necessary. Next slide. Thank you. So that ends sort of the making a referral part. So now we're going to go on to once the client's actually on an AOT court order, like Angelina was saying, there are things that there's a report that AOT classifies as a significant event. And we're going to walk through what that is for a little bit. So this is when, again, the client's already on the AOT court order. We have things such as significant events happen. So a significant event is defined by AOT as threatening either to the consumer or to the community, and it negatively affects the client's stability and disrupts their treatment plan. When a significant event happens, AOT has to be notified within 24 hours. That means the provider, so whether it's ACT, Care Coordination, or an IMT, they have to submit a significant event report to AOT within 24 hours of the event happening, and they generate that automatically. One thing I do want to say, Angelina, if you could go to the next slide. So one thing I do want to say, and these are the topics that sort of categorize what a significant event is. But one thing I do want to say before going through these, if you have a client that is on AOT at your residence and something happens, please always make sure to notify the ACT team, the care coordinator, or the IMT team. So whichever one of those 3 service providers the AOT client has, please make sure you're letting those providers know that something happens. And you can even email us at AOT. So, if you have an AOT client and you're a housing program, or if you are a staff at DHS and you have an AOT client that is residing there, make sure you know who the AOT monitor is for that specific client. So notify AOT and notify the client's treatment providers when these events happen. Say the residents had to call 911, just make sure you're communicating that. So significant events, again, these are reported to AOT by the care coordinator, IMT, or an ACT team. So if you're a housing provider, please make sure you're sharing that with the client's psychiatric treatment provider. And these are the things that sort of categorize what a significant event is. So when a client's a danger to themselves or others, when they are decompensating, when the client's decompensating, when they're using substances to the point where it is really becoming, their substance use is becoming a threat to themselves or others. It's always important when it comes to substance use, please always, let the providers know if the client is using, but the provider, so ACT, IMT, or care coordination, will enter a significant event if an event happens that is really related to their substance use. So we do have clients that smoke marijuana regularly, and no significant event may happen out of that client's marijuana use. But if we have a client that may be engaging in using other substances that are heavier, and it's really affecting their behavior and putting the other residences or even themselves at risk, that is something, to report to ACT, Care Coordination, or IMT, so that they could send a significant event report to AOT. Other significant events are if a client's ever arrested, ever incarcerated, if 911 is called for any psychiatric reason, if a client's hospitalized or they go to the psych ER, if they're not engaging in services, if they're missing. We have a lot of clients that go on UPA from the residences and curfews at 10 and they don't come back. Maybe they go on family leave longer than they told the staff at the residences. That may lead to a significant event if they're missing from treatment and missing. If a client is about to experience homelessness or is just becoming homeless. And again, the last one, which we would never hope, is if a client has passed away. So all of those things sort of entail what we define at AOT as significant events. Next slide. Thank you. So now we're going to speak about failures to comply with the AOT court order. And you guys at the residences and at DHS may, have heard the term removals thrown around a little bit, a 9.60 removal. So we'll talk about what that is. So when a client's on an AOT court order and they fail to comply with some aspect of their treatment, we have to make efforts to try to engage them, right, and get them to comply with treatment. Sometimes the client may begin to decompensate because they're not complying with their treatment. This is sort of when we explore for removals needed. And when a client is removed, that means that the CAT team is coming to pick them up and bringing them to the nearest psychiatric CPEP so that they can be evaluated. If you could just go to the next slide. So all removals are legal. And these are sort of the two main reasons why AOT client may be removed. So like I was saying, if a client's non-compliant with some aspect of the AOT treatment plan, and I'll just read this blurb right here. So the value of removal is based on the need for a psychiatric evaluation. A removal can be completed if a client is not compliant with one or all areas of their treatment plan, and there has to be evidence of decompensation and the client not appearing to be at baseline. Removal is not means of punishing the client. This is strictly for noncompliance and them getting stable. CPEP doctors are, once CAT team removes them and brings them to CPEP, it's really up to the psych ER doctor if that client's going to be admitted or not. The other reason we would do a removal is if a client is missing. If they're completely missing, we don't know where they are, the provider has done diligent searches to look for them and we still can't locate them, we will do a removal then too. One thing I just want to say about this top reason for doing a removal where it says non-compliance with the court order. So we have clients on AOT that even though they're on an AOT court order, they still might not comply, right? So they could have their medication regimen and they're supposed to be taking their medication, but they might decide that they don't want to comply with, let's say, the risperidol, right? Now, under AOT, in order to do a 9.60 removal order, the client, even though they're on the court order, can be non-compliant, but we can only do a removal if there is evidence that the client is decompensating because of that non-compliance. So you have a client that stops, let's say, Depakote, but they're not decompensating, it may be difficult to do a removal. So that evidence of the client is now decompensating because they're not compliant really has to be there for the 9.60 removal to be put in place. And like I said before, or if a client is completely missing and ACT and care coordination or IMT has tried to look for them, can't locate them, they haven't returned to the residence in several days, we would do a removal then. And again, if the client has to be hospitalized because they're beginning to decompensate. So once we do the removal, the CAT team, you go to the next slide, Angelina. The CAT team would go pick them up, bring them to the nearest emergency room, and it would be up to the ER psychiatrist to admit them. Now, when a removal is done, we really hope that the treating psychiatrist, so the client's outpatient psychiatrist, can do part of the AOT removal paperwork. In the event that the doctor can't, because some docs, like let's say for an ACT team, for example, some ACT doctors may be part-time. So if we need to do a removal on a Wednesday and the ACT doctor isn't there, we could then have 2 AOT psychiatrists sign off on the removal. So there has to be 2 psychiatrists that sign off on the removal. We would hope it would be the client's outpatient doctor and one of our AOT doctors. But if the outpatient doc isn't available, then 2 of our psychiatrists at the AOT office can sign off on it. Again, AOT reviews that removal paperwork. The case monitor reviews it, the psychiatrist, both psychiatrists review it, and an attorney if we need an attorney to review it. We have attorneys at the AOT office. Each AOT borough team has their own attorney. If a consumer is located, we have clients that are on removals, their removals are active, and sometimes the residents might call 911 before our CAT team gets to them, or ACT might call 911 before our residents gets to them, which is perfectly okay. So that can happen. And if it does happen, just, let the AOT office know that, hey, so-and-so was on a 9.60 removal order, but, his behaviors on Friday night weren't doing well. So we called 911 instead of waited for the CAT team. And again, if you have a client that's, decompensating and really, really not doing well, and you might think a removal order is necessary, please keep in mind removing a client can take several days. So if 911 has to be called in order to get them to the hospital and get them to safety, then please call 911 first. Now, if a client's missing and a 9.60 removal is in place, the provider, so ACT, IMT, or care coordination would have to continue doing the diligent searches to look for the client and try to locate them while that 9.60 removal is active. And again, like I was saying before, once the CAT team picks them up and brings them to the hospital, it's completely up to the emergency room, psychiatric emergency room staff if the client's going to be admitted or not. Next slide. Thank you. Okay, so we are getting down to the end, everybody. So this is the renewal implementation. So all clients are on AOT court orders ranging from, all AOT court orders usually don't extend past a year. So our court orders are from a year down. So you could have an AOT client that's on a 1-year order. You could have an AOT client on a 6-month court order, on a 9-month court order. We never really want them to be something like 4 months. Usually, AOT will try for that 6-month mark and up to have somebody on an AOT court order. Now, every AOT court order comes up with there's an expiration date of that AOT court order. So when that AOT court order is about to expire, at least 8 weeks in advance from the order expiring, we have to look at, okay, do we renew this client's court order and get them a new one? Do we close their case? Can they be offered a voluntary? So these are the steps of what may happen when a client's court order is coming up for expiration. So again, 8 weeks in advance, the client will have an exam with AOT. The consumer, the client, and the provider will be notified of this exam. The AOT staff team will schedule the exam with the AOT doctor about 30 days before the court order expires. The AOT case monitor will prepare the renewal paperwork. So they're going to look at what has happened in the most recent court order. The monitor looks at really that time frame. Has the client been hospitalized? Were there several psychiatric admissions? Did we have to remove the client 2 to 3 times? Were there a lot of significant events? Was the client engaged, throughout the past court order? Were there any acts of violence toward themselves, to another person? Are they complying with their, treatment plan and the services that are on the treatment plan? Once all of that is reviewed, the AOT psychiatrist will make a preliminary decision on what direction we should sort of go in terms of renewing the AOT court order, offering the client what's called a voluntary agreement. So, or if we close their case completely. Now, if the decision is made to renew the AOT court order, we would do the exam, do the AOT exam, and then we would go back to civil court to get the client another AOT court order, basically. And again, all court orders can be up to a year. And once the new court order is granted, we will make sure that you guys as the housing providers and ACT and IMT and care coordination do get a copy of that final order, and it comes in the Dear Provider packet that the AOT office will send. And if you are a housing provider and you did not receive it, feel free to reach out to us or ask either ACT or IMT or care coordination if they have a copy of the client's court order, because they should. Okay, next slide. Okay, and that is the end of our presentation. This is Angelina and my contact information. I guess we're going to open it up for a Q&A and any questions that may have come up. Thank you, everyone.
Thank you. Thank you, Melissa. Thank you, Angelina. I've been copying over some of the questions just to organize them, and while you may have touched on some of them, it's really just a handful. So thinking we can start at the top and see if anything else comes up in the chat while we discuss. The first one is, can an AOT referral come from a case manager from supportive housing for SMI consumers that are not compliant with housing program services?
Yes. It could come from anybody in the residence, whether it's case manager, nurse, program director. So residences can definitely make the AOT referral.
And I'll just add one thing, because I think this question may or not have meant like with housing program services. It's maybe not necessarily related to housing program compliance, like with the housing program services, but mostly like overall the person's mental health treatment and how that impacts, I guess, their compliance with program services and in the larger picture. There's a question on eligibility criteria. It said 3 consecutive hospitalizations, ? So I think this question may have come before you touched on the number of hospitalizations. Could you maybe recap that for the group?
Right. So the AOT criteria is if a client has had 2 or more psychiatric hospitalizations or arrests within the past 3 years, or if they've committed an act of violence toward themselves or another person within the past 4 years. So if you have a client that has repeatedly had psychiatric admissions back to back, let's say 3 within the past year, and it's due to non-compliance, they may be eligible to be placed on AOT court order. And hospitalizations, it has to be strictly psychiatric admissions. So we can't use emergency room or medical admissions to put the client on an AOT court order. It has to be strictly inpatient psychiatric admission.
Thank you. That was a question that we just received in terms of sort of defining it. We recognize that sometimes folks may visit the ED and come back. That may not necessarily count towards it, correct? Okay. I understand that it can take longer if the referral is in the community. What do you recommend when hospitals won't admit a consumer and/or EMS refuses to take the consumer, that it creates a hardship for the housing providers?
And that unfortunately, I don't know if you want to speak on that, Angelina, happens often.
It definitely does happen often. I think that if there's already a relationship with AOT, I think it's really important to reach out to AOT. Each of our teams have a psychiatrist, a medical director, and they have really great relationships with the hospitals. I would also recommend reaching out to OMH and having a further discussion as to like what we can do with this particular individual. I think that a lot of times when I'm receiving emails about individuals who are not on AOT or who have not had a history, I get emails from OMH trying to advocate for our providers in the community. And there's definitely major involvements with the hospitals. So I would definitely recommend reaching out to them.
The next question, most recently upon request for AOT, the hospital is saying the client must agree to the process. Is that true? Does someone have to agree to it?
Do you want me to answer?
Yeah, I think you touched up on that. But
Yeah.
maybe they came in later. Go ahead,
Yeah,
Melissa.
so no, the client doesn't have to agree to it. The hospital and AOT may need medical records, and they have to agree to signing the consent to get the medical records to prove that the client meets criteria. But if they don't consent, then the hospital or the AOT office can subpoena those records. So technically, no, they don't have to be in agreement with the AOT court order. Most of the clients aren't in agreement with the AOT court order. So no, it's not necessary that they agree to it.
Okay, I think there's another question here. Does someone who's a power of attorney, does their decision override an AOT decision? Or does AOT trump the POA requests? And maybe, I don't know if that's a typo. And Jing Lee, I'll try to unmute you. I have to figure that out. I'm on my own here. Cynthia, could you try to unmute Jin Lee and maybe add him to panel in case there's anything he wants to add? Sure, Cynthia.
I'm sorry, at who?
Jing Lee, who's one of the participants, if we can move him to panel access or allow him to unmute. Thank you.
And regarding with the power of attorney, that would be a legal issue that, would come up regarding the decision-making for the client's care. Say, if the power of attorney disagrees with part of the AOT treatment plan, it would probably have to go to our legal department to really discuss, since power of attorney is also, a court order, or signed legally by an attorney. So that would most likely be referred to our legal office, and we would all, speak with the power of attorney to sort of figure out what the best decision making is.
Right, that's really a legal matter that our attorneys get involved in, not so much us, but more our mental health legal department.
All right. Let's see. We're getting more and more questions, so I'm losing track of where we're at. Oh, this is an interesting one. This may be more on you guys' side, but why have the AOT caseloads increased from 15 to 20? Is it just demand? I'm not sure.
The caseloads have increased, no, more than that.
More than that.
I
By
think maybe this is on the provider's end, Kathy.
Okay.
Yeah, because AOT, and just so that everyone knows, we have, our monitors are carrying more than 60 cases at any given time. So I think that's more of a question for providers. And unfortunately, I wouldn't know that, Kathy. I don't know. You may can answer that question.
Okay. If a client is missing, how can you do a removal order? What's the first step?
Do you want to answer or you want me to answer?
Okay, Melissa.
So if a client's missing and we really don't know where they are, the first step would be for either ACT, IMT, or care coordination, whichever service the client has, they would have to do what's called a diligent search. So AOT providers are trained in what a diligent search is. They would have to go in the community, go to the residence, go to the shelter, look for the client. And there's other steps that are entailed in a diligence search. They would have to look for the client twice a week, wherever they think the client might be. They have to call the morgue. They have to call areas, the hospital's client might frequent, other hospitals that the client might not frequent, check if the client's been arrested. So once that diligence search has happened and if the client's still not located, they would submit the diligence search with a significant event report to the AOT office, and then we would issue a removal and go through the paperwork to do a removal.
Right, and that paperwork is completed by the provider. So they already have the paperwork that needs to be, submitted to AOT.
Yeah.
If further information is required by AOT, then it needs to be resubmitted again. Perhaps, as like Melissa said, diligent efforts by the provider is essential. If there is no diligence search happening by the provider, we cannot legally remove a consumer. The provider must make their efforts to locate our consumer 2 physical attempts per week.
Thank you. So I think we touched on the other one. We will circulate the PowerPoint for folks who maybe missed the first couple slides on eligibility. The next couple questions, who's the contact to make an AOT referral, right? Like in terms of like, once you gather everything, what's the first step? What do you do when you want to make a referral? Where do you go?
So there's, we have an AOT referral form for the 5 boroughs. So the AOT office can be contacted again. We will be sending out this PowerPoint, and the telephone numbers for the AOT office will be on this PowerPoint. So if you want to make an AOT referral, you can call the number of the borough the client lives in and request an AOT referral form, and fill out the AOT referral form to the best of your ability. And then you can submit it back to the AOT office. If you have a client that, let's say, is street homeless, then you would make the referral to the AOT borough where the client may stay in the most. But you can get the AOT referral form from our AOT office. And with this PowerPoint, you'll have all of the telephone numbers. You'll also have Angelina and our email addresses and our telephone numbers, so you can call us and ask for a copy of the AOT referral as well.
Hi, good afternoon. This is Jing Li from OMH AOT. Finally,
Hi, Jing.
I'm unmuted. Okay, first of all, I want to thank you everyone for participating in this, training on a Friday afternoon. And also I would like to thank our colleagues at DOHMH for this great presentation. So I can answer some of the questions mentioned earlier. I think one person asked if a housing case manager can make AOT referral. So basically under the current statute, anyone can make an AOT referral, including the individual's family members, providers, therapists, parole officer, and even adult roommate. So basically for anyone in community to start the referral, the process is very simple. So you just need to reach out to DOHMH, the right borough team, based on the current address of the individual. So if the individual lives in Manhattan, then the referral goes to Manhattan AOT team. If the individual lives in Queens, that goes to Queens AOT team. I just want to clarify the roles and the responsibilities between OMH AOT and the DOHMH AOT. So under the current statute, AOT is implemented at the county level. That's why in other counties, upstate New York, it's the local county DCS, Director of the community services that run AOT program. And in New York City, we are very fortunate to have DOHMH as one agency that runs AOT program. So basically, DOHMH is responsible for AOT referral, investigations, and also the implementation and daily monitoring of all AOT cases. And for OMH, we provide the statewide oversight, so trying to fulfill the statutory obligation of monitoring and oversight. So our unit, each quarter, we randomly select 5% of AOT cases, and based on the individuals and treatment plan, we go to the providers, including care management agencies, ACT teams, housing providers, if you are listed, to review the 6 months records. And the purpose is to make sure the individual is receiving all the treatment services as court ordered. So mostly we will clarify or address any deficiencies we notice with the program directors. And at the end of the quarter, a copy of the report will be sent to the agency leadership as well as DOHMH AOT program. So also, if there's persistent pattern of deficiencies and there's no change, sometimes we might have to report back to the court, the judge, letting them know, the providers on the treatment plan are failing in terms of the delivering all the court-ordered services. So far, we have rarely done that, but that's one of our legal obligations. Someone mentioned about power of attorney.
Yeah.
Yeah, I agree, it's a legal question, but based on my knowledge, I would think if someone already had power of attorney, by law, that person should be involved upon the AOT petition process. So because the power of attorney or the individual's health proxy should be receiving a notice of the AOT investigation and the petition. So they should be involved during the whole process. And I don't think, because it's a legal process, they can go to the court hearing along with the individual. So if they have any question, disagreement, they can directly tell that to the judge. And ultimately, AOT is the judge's decision. So the doctors, DOHMH doctors, hospital doctors who evaluated the individual will provide the reasons why this individual meets all criteria and needs AOT. And then the mental hygiene legal service attorney and the individual's family members or power of attorney can argue why the individual doesn't need AOT or will not benefit from AOT. And ultimately, it will be the judge's decision to grant AOT order or not. So I don't think the power of the attorney can override the judge's decision, but they should be in the process of AOT petition, unless this individual was later on added on when the client has been on AOT. So they might not be able to overturn the AOT decision, but they can definitely request for a court hearing to challenge the decision in a sense. So argue the case should be heard again, and then they can present their reasons. And just like an appeal, and ultimately it will be the judge who makes the decision as well.
Thank you, Jen. Thank you. I appreciate that feedback. Further clarification and more information for folks. It is a complicated process. So I think the PowerPoint is the beginning, right, of getting to know. There are contact information listed in the PowerPoint. Should you have further questions, you'll be pointed in the right direction. We received an interesting question in the chat. If an individual is seeking to apply for a position as an AOT case monitor or case manager, where would they apply? Since I guess the advertisements aren't always seen. I'll turn that over to Angelina.
Oh my goodness, we are in need of case monitors, not to be an advertisement right now. But we definitely need, the website is, correct me if I'm wrong, Kathy, is it nyc.gov?
Yes.
Yes,
Yeah.
okay. So that would be the website. You can maybe enter it, Kathy, if you can in the chat
Yeah,
area.
I'll plug it in the chat. It's nyc.gov. There's usually a page on careers, and it'll give you everything throughout New York City. So you have to filter down to the organization, which is Department of Health and Mental Hygiene.
Correct, and we have many availabilities for AOT case monitor.
We have two hands raised, Kevin Clark and Victoria McKnight.
So I'm not sure if folks have the ability to unmute themselves. Do you guys want to plug your question in the chat?
I can unmute them if that makes it easier.
Okay, sure. Yeah, thank you. Well, we're sorting that out. I'm seeing we're still getting questions about the information. We will share out the PowerPoint to this. We have the contact information of all the registrants, and so we'll make sure to send everyone who attended here a copy of the PowerPoint with all the information. We're getting some thank yous. Thank you all. Are folks unmuted yet, Cynthia?
No, for some reason, I'm not able to unmute them.
Yeah. So I would say, Kevin, and I forget the other hand, I suggest you plug in any questions in the chat. Because of the size of the webinar and attendees, we opted to make this webinar because a lot of times there are inadvertent interruptions. Someone unmutes, that we want to limit the disruptions. There's a question here. Do you work with I guess they're trying to say CAT teams? CHAT team for 2010Es. The 2010E is housing. It's a housing application. Patrick, not sure if you want to elaborate.
Just to let everyone know, we work very closely with the CAT team. The CAT team is part of our AOT team, so just so that everyone's aware, the 2010E is typically completed by the housing provider and sometimes the providers themselves and the hospitals, but we don't complete that in AOT.
Got it. Thank you. Let's see, I think that was all of the questions. The last one, last but not least, and I guess that we'll sign out with this one, is the AOT court order the same as a mental health warrant?
Mental health warrant?
Yeah, that it is not.
No.
Yeah, it's my understanding that the mental health warrant is a different process and goes through the legal system with an attorney and the mental health courts. So it is a separate process from assisted outpatient treatment.
Mm-hmm.
All right, I just want to thank everyone who's attended. I want to thank our presenters. Again, we will circulate the PowerPoint, and please keep an eye out on your emails. We will circulate to our network the next webinar series that the topic will be Adult Protective Services later in July. So thank you all for attending, and we look forward to seeing you at future webinars. Have a wonderful weekend.
Thank you so much.
Bye. Thank you, everybody.
Bye-bye.